Welcome to Unit 23 for Anatomy and Physiology 2 students. In this chapter, we're going to be talking about respiratory or pulmonary physiology. The words respiratory and pulmonary are going to be used interchangeably here. Essentially, pulmonary, we usually talk about more clinical scenarios, and respiratory just as for general anatomy. Last week, keep in mind, we talked about just where the respiratory organs are located, right? What features they have, what are the main structures anatomically that are found in the respiratory system. So today we finally want to talk about how does the respiratory system actually function, and we're going to go into some clinical scenarios that are usually used in the lab to evaluate respiratory function. Now, keep in mind, essentially, when we talk about pulmonary or respiratory physiology, we're talking about ventilation and perfusion. Ventilation refers to the air that's actually going through the airways on its way to alveoli where gas exchange occurs, and perfusion refers to the blood flow that will carry the oxygen and carbon dioxide and those other gases as part of the respiratory function. So again, in order for respiration to be successful in the body, in order for all the cells to ultimately get their oxygen, both ventilation and perfusion have to occur and they have to be balanced. So again, ventilation is the air passing through the airways, perfusion is the blood flow. Now, average resting respiratory rate, which is one of the main vital functions, is usually 12 to 14 breaths per minute. Again, average resting respiratory rate, 12 to 14 breaths per minute. Obviously, that varies from person to person and depending on different situations. But this is what we usually keep as standard. Now, when we're talking about our thoracic cavity, where respiration takes place, keep in mind, right, we have that muscle, the diaphragm, we have the lungs, we have the ribs, obviously the rib cage, and the different intercostal and other muscles that help us to breathe. So we're going to look at three main components when we inhale and exhale the air with the help of our diaphragm and the lungs and other structures there. So again, when we are thinking about respiration, we're thinking about inspiration, which is the inhalation of air, and exhaling, getting rid of the air, is the expiration. Okay, so in order to simplify this rather complex topic, let's talk about just three main components. So we talk about what happens to the diaphragm, what happens to lung volumes, what happens to the intrapulmonary pressure inside the thoracic cavity. So essentially the best way to think about this is that air is a gas, right? Whether it's a gas like oxygen, nitrogen, carbon dioxide, other gases in the atmosphere, and we need to somehow get that gas from the outside of the body into the body. How are we going to do that? The best way to do that essentially is to create negative pressure inside the thoracic cavity to pull or kind of suction the air in from the outside to the inside. Right? So first thing that happens essentially is the diaphragm contracts. When we say diaphragm contracts, it means it goes downwards. This creates negative intrapulmonary pressure. That is the pressure now used to suck the air into the thoracic cavity, into our lungs. And so as we do that, we obviously increase the volume of the lungs. And so as we can see that here, right? Up arrow means increase in volume, higher going higher, and down arrow means going down. So as intrapulmonary pressure decreases, we're pulling in more air. We have contracted our diaphragm, and now we are expanding the lungs. Okay, so when does that happen? This happens during inspiration or inhalation. Then when we breathe out the air, right, get rid of that carbon dioxide, get rid of the waste gases essentially, right, on exhalation. What happens? So multiple components take place. Keep in mind also one important feature here is that even though we kind of did more work here when we need to pull the air in, to get rid of the air, we do sort of less work because we rely primarily on the elastic recoil of the lungs. Lungs histologically have elastic fibers in them that kind of spring back and allow the air, the exhale gases to be pushed out of the lung. So now what happens here? The diaphragm relaxes, it goes back to its normal state. Obviously, lung volumes decrease as we're getting rid of the air, and the intrapulmonary pressure has to go the other way. Right? As you can see, all of these are opposites. So again, we're getting rid of the air, we're decreasing the lung volumes, we're relaxing our diaphragm, and the intrapulmonary pressure goes back up. When you're evaluating these conditions, make sure to take a look in the book to see the illustrations in the lab manual and in the textbook, seeing how this appears in terms of the use of the muscles and the diaphragm. It's going to help you understand how this works. Again, pay attention to these specific criteria that are used here. Another important concept here before we get into more kind of clinical understanding is keeping in mind that essentially when we talk about balance of ventilation perfusion, this is not just a kind of theoretical concept. It actually exists as reality in medicine for pulmonologists, for respiratory therapists, and in some cases we have a way to kind of talk about how we can actually measure that balance, right? So there's a mathematical formulation called the VQ ratio. V refers to ventilation, Q is to perfusion. So there is a normal VQ ratio that a person who has healthy respiratory system has, and then there is VQ becoming infinity, the ratio of V to Q becoming infinity, or ratio of V to Q becoming 0. Let's talk about these two extremes. Now, even though they might not be exactly occurring in the normal body, but under certain pathological states, definitely they do occur or occur as close to that as depicted here mathematically. And this is just a good illustration of how we can think about the physiology of the lungs and what happens there in terms of ventilation and perfusion. So when we have that state of V over Q becoming infinity, the best example of this is essentially what's called pulmonary embolism. By the way, how do we get this ratio, right? You can say that essentially ventilation is taking place normally, right? Air is passing through the bronchial tree, through the trachea, through all the airways. That's fine. Okay, but so we get this, set this to, let's say, 1. But Q, which is perfusion, somehow has been blocked. Maybe there's a blockage in one of the pulmonary blood vessels, right? This is what happens sometimes, something called, again, PE or pulmonary embolism. An example would be deep vein thrombosis that has dislodged and now has migrated through the body to the lungs, causing that blockage. If that occurs, what happens? Ventilation is happening fine, but Q now goes to 0. Something over 0 basically becomes infinity mathematically, and so obviously this is a medical emergency, and usually CAT scan with a VQ scan with a basically nuclear medicine scan would be done here to assess that patient, and then treatment provided based on the findings. For VQ over 0, this is an opposite effect. Here essentially perfusion is fine, all the blood flow is going everywhere, right? The red blood cells are there, hemoglobin is there to pick up the oxygen, everything's fine, but for whatever reason, there is a blockage in the bronchial tree, right? So essentially, right, V becomes 0. This is what we call dead space. This could be for a number of different reasons, such as, for instance, bronchi blocked by a tumor, by a cancer, but some kind of a malignant neoplasm, some kind of a growth, or something else. It might be an object that has aspirated, that has completely blocked off a part of the lung, essentially. But again, if Q is fine, is normal, but V is 0, right? 0 over something is just 0, so that gives us that dead space condition. Okay. The rest of the discussion, we're going to talk about the clinical aspects of what's called spirometry or pulmonary function testing. PFTs or pulmonary function testing is something that's done quite often in clinics and hospitals to assess respiratory function in this very rather non-invasive, we'll say, way, where instead of taking a chest x-ray, a CAT scan, MRI, or even like a bronchoscopy for patients who have something wrong with their lungs, some kind of lung pathology, what we can do is also something called PFTs, again, or spirometry. Again, we would normally do this in the lab, essentially give you a spirometer that you can breathe into, and this is what's done in a clinical setting, except with a computer and a more sort of sophisticated machines. But basically, the overall procedure is that the patient would be sitting at a table and have this tubing going to their mouth, and the doctor would tell them to either breathe normally first. When they're breathing normally, right, we're kind of assessing their normal state, and then to exhale forcefully, inhale forcefully, do these different kinds of maneuvers for a period of time. And the computer actually is able to measure different kinds of lung volumes and assess what is actually happening in the respiratory system. Again, you cannot make all conclusions for every single pathological state in the respiratory system here, but definitely something like asthma, different kinds of bronchitis, COPD, emphysema, certain other common disorders could definitely be assessed very well, and they will supplement other medical tests that are done by the pulmonologist. So let's look at respiratory volumes and respiratory capacities that are normally kind of seen here. So basically, one of the ways we're going to assess this here is that there's going to be a curve that you're going to see, and first is essentially this is time, these are volumes. We're going to look at it. You have all these curves in the book, so you can follow this. Basically, when a person is breathing normally, we measure what's called tidal volume. This is usually around 500 ml. The amount of air exchanged with each breath. Again, tidal volume, tidal breathing, right? Normal breathing. It's going to look like a curve like this. And then they're going to tell you, now exhale forcefully. So this is going to be expiratory reserve volume, the amount of air you can exhale forcefully. Okay, this is going to kind of drop. Okay. And so that's going to be an ERV, expiratory reserve volume, how much volume you have in reserve, right, that you can access by forceful exhalation. Then they're going to tell you to breathe, again, breathe normally, and then breathe in, inhale forcefully. That's going to be our inspiratory reserve volume, IRV. So the amount of air you can inhale forcefully. Okay, it's going to be here. And we can go back to normal. And essentially, the rest, the way we're going to think about this is that there's always, no matter how much you're breathing, there's always going to be some air trapped in your lungs that you can't access, that you can't measure directly. It's very difficult to kind of maybe visualize or kind of get access to, but that air is there. If you're very healthy, if you're a young person, you probably have this very small volume, this is what's called residual volume. If you're older, if you have history of smoking, COPD, emphysema, chronic bronchitis, other medical conditions that affect your lung capacity, your residual volume probably has expanded. The bigger the residual volume, the more difficult it is for that patient to breathe on a normal basis, and very often they be either dependent on oxygen or will have certain other disabilities related to abnormal respiratory function. Okay, so again, residual volume, which would be over here under this curve, something we cannot measure directly, but can measure some kind of mathematical formulas, manipulation of numbers and things like that. And again, it is there, that appears on the curve. Again, residual volume, right? Residual amount of air left in the lungs after you exhale all the air. Another way to look at this, the rest of the explanation on the chart is basically think about, let's say, right, so I told you first we had that tidal volume. What about if you add all the volumes you have in the lungs? So these are different capacities, right? So when you add all of them, this is going to be total lung capacity, right? This could be up to something like 6,000 ml, right? The entire curve from the bottom to the top. Again, perhaps not very useful for us here, but just something to keep in mind when you're interpreting the chart, when you're doing the homework, trying to understand how this works. And then we have two other mathematical kind of formulas here. They're useful, important factors. One is called vital capacity, another is called functional residual capacity. And vital capacity and VC and FRC are used clinically quite often. And vital capacity essentially refers to tidal volume added to ERV and IRV. So again, tidal volume plus expiratory reserve volume plus inspiratory reserve volume, that gives you your vital capacity, which essentially means what is the combination of these vital factors that your respiratory system uses as measured through spirometry. And functional residual capacity is essentially amount of air normally left in the lungs after normal exhalation. And this is referring to, so ERV plus RV, right? So ERV plus residual volume. Okay, so towards the bottom of the curve gives you functional residual capacity, or the amount of air normally left in the lungs after normal exhalation. Okay, again, take a look in the book for definitions for all of these different values. You can look at the numbers as well. Again, I don't recommend exactly memorizing every single value that attached to any of these features, other than maybe the tidal volume, which is kind of the basic one, like 500 ml. But definitely keep it in mind as you're doing homework and to help you understand what is expected, what is usually happens in a patient when we do these measurements. Okay, and last but not least, we want to talk about also how the acid-base chemistry is influenced by the respiratory function. So we already know probably that the body has different ways to maintain the proper pH. Remember, proper pH of the blood is 7.35 to 7.45, and that very narrow pH needs to be constantly controlled by the body. And the way it's done is that essentially we have the respiratory system that controls pH, we potentially have digestive system controlling pH, and very importantly, the urinary tract with the kidneys, which we'll talk about later in the semester, also have an important impact on controlling pH of the body. Now, from the point of view of the respiratory system, the way we think about this is that everything is about carbon dioxide here. Carbon dioxide, or CO2 gas, travels in the blood as carbonic acid, right? So CO2 gas cannot just be soluble normally in the blood until it becomes carbonic acid. Some CO2 is bound to hemoglobin, but mostly it's found as carbonic acid. So when you think about that, so we have carbonic acid in our blood. So what happens now when we have different states of breathing? Sometimes we can hyperventilate or breathe faster than normal, and sometimes we can hypoventilate or breathe slower than normal. Now let's take it one at a time. So if a person is hyperventilating for whatever reason, whether this is due to some kind of medical abnormality, whether due to a state of exercise or something else, basically what happens in terms of the chemistry? So when you're breathing very fast, you're getting rid of carbon dioxide faster, right? You're losing carbon dioxide. So CO2 goes down. As you're losing carbon dioxide, you remember, well, carbon dioxide is actually acid in the blood. So as I'm losing acid, what am I doing to pH? I am increasing the pH or making it more alkaline, right? That's why the person then can go into alkalosis if no compensatory mechanisms are activated at that time. Now, usually the body does compensate right away, obviously, by using other systems, again, like the power of the kidney to either excrete or hold on to more acids, and in other ways. But by itself, again, during hyperventilation, as you're losing more acid amounts are dropping, and so your pH now will, of course, increase. You're becoming more alkaline, and so that gives you alkalosis. In the other state, if a person is hypoventilating or breathing very slowly, slower than normal, hypoventilating, they're breathing so slowly that they're not having enough time to get rid of that carbon dioxide. So it's staying more and more in the body. More carbon dioxide is accumulating. Remember, again, carbon dioxide is acid in the blood. As you accumulate more acid, your pH starts to drop and you become acidotic or going into acidosis. Okay, again, during hyperventilation, you're breathing so slowly that your carbon dioxide levels are accumulating in the body. What is the body going to do, right? So as you accumulate more acid, the pH has to drop into the acidic range and you become more acidotic. Again, obviously, the body has a way to compensate for this. And so this respiratory acidosis will be compensated through metabolic other means by the body. And again, we'll talk about more of this throughout the semester when we get to other organ systems. Again, review all of this material in the book and the lab manual, and pay attention to all the illustrations, the diagrams, and pictures for this chapter.